I'm Dr. Rosenquist. We're presenting today a hopefully relatively brief in-service on consent and capacity and how it relates to our psychiatric patients. With me today is Stuart Fisher, who's from our legal department. He's going to make some remarks about the specifics of legal, but I kind of wanted to spend a little time talking about the background and how this sort of comes about. So what we want to do is, how is consent defined? What are the principles which govern that process? And a separate but related principle is capacity. How is that determined? What if we do, and then the questions we have is, what do we do if a patient lacks full capacity? How do we handle that situation in our field? And who has the legal responsibility to obtain consent? And then hopefully we'll also speak to what are the specific responsibilities that nursing may contribute to this consent process. We'll start with a little bit of Shakespeare, because it's early in the morning and you're wide awake for the time being. But this was one of the lesser known plays called All's Well That Ends Well. And in this play, Bertram is this low-born woman, and she is in love with, I forget his name, he's the Count though, and what happens is she has a healing art, so she goes to the King of France and says, I think I can heal you, but it's going to cost you something, and the thing it would cost you is you got to make it so that I get married to this guy. But the whole play is ridiculous after that, how much she's chasing him down because he's not really worth it. So at one point, she, clear back in the 1600s, was talking about informed consent. What does she say? Dear sir, to my endeavors give consent. Of heaven not me make an experiment. I am not an impostor that proclaim myself against the level of mine aim. But no, I think, and think I know most sure, my art is not past power, nor you past cure. So the principle of, we've got something to offer, but you gotta tell me that it's okay for me to proceed to do that. That's what consent is. There are a number of principles that underpin consent. The first is autonomy, second beneficence, non-maleficence, and then justice. So they'll start in the middle. So beneficence is doing something good, non-maleficence is not hurting the person. So that's always the tension that we have whenever we're trying to help someone. We also recognize their autonomy, the ability of individuals to make decisions in relation to their own bodies. And then there's justice, which has to do with how we view different people in this system of thinking about them. All right, I would say that consent is a balancing act that we have to do. Because patients have a right to effective treatment, the ECT physician must be persuasive. Okay, that means that I recognize that this is something that's going to help you. You may not think that right now. You've been watching too many movies where ECT is seen as something that's going to harm people. So I need to persuade you at some level that this is a good idea. Otherwise, if I don't do that persuasion, then you'll say, well, I don't think so, doc. And we move on and you don't get well. Because patients have the right to refuse treatment, you also have to provide an honest and reasonably full disclosure and avoid coercion. That's the other side of it. On one hand, I have to be persuasive. On the other hand, I can't just blow past you and smoke and mirrors, right? Because illness and medications may affect understanding, the standard of care requires an assessment of capacity of each patient to consent for treatment. So we are dealing with individuals in this field who are likely to have a degree of inability to process what's going on. The brain is our processing organ. These diseases affect the brain, so we're going to have to factor that in as we think about it. So the questions we have are consent. The earliest precedent just says, do you agree to be treated? That's what the Shakespeare play was about. So if that's simple consent, if you say yes, if you say no, then you can't treat. That's the simple idea. Today, there are two more complex questions are required. Did the physician provide the patient with adequate information? And based upon this information, did the patient give consent? So those are the additional standards, and I think Stuart will have a chance to expand on that a little bit. So let's talk about how the consent is originally arrived at. So patients who come here for ECT don't just show up on ECT day and that's what we're just going to throw them in. No, I've got to do an ECT consultation ahead of time, and where I'm confirming the psychiatric diagnosis, all the severity, documenting the adequacy of previous treatment, assessing the urgency of symptom relief. Oftentimes ECT is the choice when things are really going bad and you need to try to shut it down. Estimating the likelihood of the good response to ECT versus alternative approaches. Appraising the medical risk, we have to determine all of that. Examining their capacity to provide informed consent, and then any tests we have to do, and then an overall recommendation for or against ECT. I don't send everybody to ECT. Some people, it's not a good choice for them. But this is what goes into the consent process. This information is what we use to make those decisions. This is a little bit of a small screen for the amount that's on here, but this sort of says that the consent process is a number of sort of components to it. First of all, the consent is voluntary. It can be withdrawn at any time. That's the understanding. And we would reconsent, and just do another consent if things change significantly. So if you have a situation where, I think we need to switch from right unilateral to bilateral treatment. I'm going to go back to the patient and say, this is what we're going to do today. I don't need to go back to the form to do that, because the consent is not the form. Let's be clear about that. The form only just codifies for a legal purpose what the consent is. The consent is this process of interacting with the patient. So you're going to talk about risks, the nature of the illness, the nature of the treatment, the treatment outcomes you expect from this, right? Is this going to help me or not, doc? And then what were the alternatives? Those are all the pieces of the puzzle for consent. So just to go through those again, you got to understand what your illness is, and some of our patients don't, right? Insight, what's that? Insight is the ability to recognize that you have a problem. You have people with insight, sometimes it's not full insight. Sometimes a little bit of insight, and you can build on that insight. And as people get better, you'll see their insight sometimes improves, right? So capacity, I went from Shakespeare and I'm going to go to Thoreau. His little statement there, it takes two to speak the truth, one to speak and another to hear. Right? So it's any conversation is a two-sided activity. And in this passage, he's really saying how the relationship makes it so that you get past a lot of things that you wouldn't if you didn't have the right relationship. So in other words, if somebody's going to try to sell you something like insurance or something you really don't need, you're not going to exactly hear it the same way when it's coming in that form. So the essence, as I view consent with my patients, is I have a relationship with them. They need to trust me, and they need to trust the entire team to be able to do what's right for them. Because sometimes we're going to persuade, sometimes we're going to put. You really need to think about it, as you would with a friend. I know you're saying I don't want to do this today, but guess what? Here's why I think you should. And we've seen the situation, right, where people have consented, but now it's like, I don't want to do this today, right? So let's talk about capacity. What is it? The physician determines incapacity and seeks substituted decision making. So that's the situation where if I don't think you can make the decision, you don't understand all those elements enough, then you might get in Georgia the law is any any spouse, next of kin can provide consent. In some states, ECT requires a special, you got to go before the judge to declare the patient is incompetent, and then appoint a guardian and do all that sort of stuff. In Georgia, it's much simpler than that, thankfully. So the things which determine capacity for consent, again, understanding, can they understand the relevant information? Can they appreciate it, sort of apply the information to their own setting, situation? reasoning? Can you reflect on the treatment options and consequences? And can you communicate that choice? The ability to express your decision. These are sort of the general areas of capacity that we pay attention to. So we know that any diagnosis or condition that affects your thinking can affect your ability to make medical decisions, right? But just because you're struggling in one area doesn't mean you can't make a decision in this other area, right? It's an important point to make about capacity is it's for a specific thing. It isn't a general label like, okay, you're incapacitated. Now some people are so incapacitated that they can't make a decision about anything. That might be true, but you still have to go through the process to determine, for this thing, do you understand what it is that we're trying to do here? So learning disabilities, if someone has a stroke or any neurologic illness, dementia, all of our psychiatric disorders, and I've already mentioned this main point about insight. Insight is the ability to tell that you have an illness and that there's a need for treatment. And that's actually been the strongest predictor of capacity for psychiatric patients. When insight goes, it's really hard to make a decision. So if we have a patient that we have, we think we have grounds to question the capacity. In each case, we got to see where that's coming from. Like, is this remediable? Is this something we can actually do something about? So if someone is in a delirious state, for example, they're dehydrated, they have hypoxia, they're infected, they have a bunch of sedating medications, or maybe they're medication withdrawal, you're going to probably try to treat all of that as best as you can to get to the best capacity this person can. Sometimes having someone else give the information can make a difference, which is where I think having a full team can be valuable. A nurse can say, oh, you were worried about the IV. Well, that's real easy. We just do this and this and this. Oh, okay, now click, click, click. There's a little bit of something that I was worried about. Or the anesthesia team has to supply a piece of information. Or maybe it's a family member who can come in and say, Mom, I really think you need to have this. Because don't you know, this is what we've been seeing, sort of almost like an intervention or an opportunity for them to reflect on themselves as other people will present themselves to them. Psychotic, catatonic patients, medications is reasonable. I know in the general situation, you wouldn't say a person has capacity if you gave them lorazepam, because their mind is altered by this medicine. I don't really buy that. I think in many cases what we're doing here is making their mind a little bit better able. So we have a catatonic patient, for instance, who cannot speak, cannot move. Lorazepam is on board. They can actually nod their head and say, I don't want to be in that state anymore. So it's not a you have to take each individual situation as it is. You might try to do medication until the patient can have the capacity. So, but it's also true that if you've tried all of this and you can't get the person to the point where they can make consent, you can actually do, and you feel like it's urgent, then you don't waste time. You get somebody, a family member, to help you, and you'll just say, I don't think this patient has the capacity to consent at this time. Which brings us to our consent form. And I think I'm done after this. I'm going to let Stuart step in, but we've all seen this. All of these elements of consent are here. We have a very simple statement about the benefits, just because we have different conditions which people are being treated for. So we just say it's going to improve your symptoms of mental illness. There's a long list of risks statements here. The first bunch are related to ECT itself. Anesthesia asked us to incorporate the anesthesia risks in here. At one point, they wanted us to use a general surgical consent form. You can tell how happy I was about that, because it was describing, you could die from this, you could get infection. Well, that's not. And one of the struggles for us being in the surgical world is we're not surgery. So all the things that really apply to a surgical world don't necessarily apply in this case. Well, some do, some aspects of this do. The anesthesia certainly does. We have to speak to the alternatives. What can you get if we don't do this? What's your alternative? And then we have the actual kind of writing the consent part, and we've all looked at this 1,000 times. Patient signs, the physician signs. Physician also documents that he in fact presented this information to the patient, right? It's not just enough to just say, oh, I'll sign this here and they sign this there. I further certified the patient was given an opportunity to ask questions. And so any physician can document here, could be resident, could be Dr. Sergi does the consents out at ECRH most of the time. And any adult may witness the consent. So a family member can do this, you guys can do this. One of the questions was, if I'm witnessing the consent, what does that mean? And I think this is a good transition for me to bring Stuart up, because that was one question.
Sure, I think that's excellent. Thanks, Dr. Rosenquist.
Yes.